new in-office COVID test. Right now for the practices that are applying for the, and that's one thing I'll share with Kay, and so that she can help the offices get this CLIA waiver through the CMS, and it takes 2 days. So they can be approved to be a CLIA waived facility, which means they are not declared as a lab, and they're able to run these tests on their own without any kind of supervision.
Yeah, you know, I'm super excited. First of all, I want to say welcome to everyone. We are so glad that you're joining us today. We are super excited. You know, we decided to put this West Coast webinar on because we realized that sometimes when we did them that you guys may have been busy. So we had quite a few sign up. We actually did start off a few minutes early because Laura has a lot of information to share with us. I mean, like, it's really good information. We were just talking and she was telling me how much she just got an office last week. So
this week.
Oh, I'm sorry, this week. So we are super excited because there's nothing that makes us more happier than seeing that our offices are getting paid and that they're able to take care of their teams and, you know, buy the things that they need. So to run a good practice, right? Because I mean, it has to be profitable and we all need to make a living and also make an income. So we are super excited about putting these webinars on. So this is our first one. It's a Friday afternoon. I know we had a large sign up, so we're hoping that we'll get more on, but I'm gonna go ahead and start going over the CE guidelines so that we can start right away. Number one, please make sure that you registered in your legal name if you want to receive CEs for this program. It's really important that you register in the name that's on your license. Sometimes we tend to put our nickname on and then they won't accept it. So just let us know if you had any problem with that. Also, you need to make sure that you sign in. If you registered and you want CEs, make sure that you sign in on your own device. That's going to be really important that you log in on your own device. That way that we can see at Benco that you're on and we can give you credit for the hour. Please make sure that you stay on for the complete hour in order to receive the CE. There will be a survey at the end when you receive your CE. Please let us know what you want to see more of. We're here for you. We want to make sure that we take care of our offices. We really care at Benco how you're doing out there, and we want to provide to you as much information as we can. So please make sure you fill out that survey. We would really appreciate that. Also, if you're listening on a cell phone device and you've logged in with pushing the button, you're fine if you've logged into the webinar. If you've dialed in on your phone, we cannot see your name, but we still want to make sure that we give you credit. So we're going to ask that you please send me your name, the title of today's course, and your telephone number to practicecoaching@benco.com. Again, that's practicecoaching@benco.com. Don't worry if you didn't get that. I will also go over it towards the end of the program, so don't worry about that. I'll make sure I go over it again. I also want you to make sure that there's a Q&A at the bottom. Laura is so open to answering questions. So please, during the webinar, we want you to get involved. So type in your questions, and then we're going to allow the last 10 minutes for Q&A. And then if we don't get to all the Q&A, Laura has agreed to actually make sure she answers all the questions. And then everyone that came on live today will receive a copy of the Q&A. So with that being said, I'm so excited. I mean, you know what, Chuck Cohen, I am so honored that you came on to welcome the West Coast for us this afternoon. I really appreciate that. So with that being said, to introduce our speaker, I'm super excited to introduce my amazing boss and the director of Benco Dental, Chuck Cohen.
Well, Kay, thank you very much. We're glad to be here, and we're really glad to put this program and this series together to serve the customers on the West Coast as we do the customers on the East Coast. I think you guys are going to be very impressed with the program today. Lori Owens is one of the foremost experts in the United States on dental insurance billing, specifically around undercoding, cross-coding, and medical coding. And she's going to spend a lot of her time today talking specifically about how every dental practice can learn how to medical code and how they can increase their revenue and increase their patient happiness. So because patients generally can be more satisfied when you know how to do all the right insurance coding. Not only that, how you can protect your practice from any sort of fraud or any issues around that. So she's going to cover that as well. Lori, this is, I think, our third webinar that we've done with you so far, and they've all been very well attended, and you really have shared a tremendous amount of information with our customers. So thank you very much, Lori. I'll turn things over to you. Everybody have a great weekend and a happy holiday next week.
Yes.
Bye-bye.
Oh, so excited to be with Benco. I can tell you as a Benco speaker here, but also as a Benco user at the practice. So I want to make sure what you understand, when I'm at the practice and when I was in practice, we use Benco. So I like Benco. I have to say I love the reps and I love the people that were attentive to what we needed as a practice. So just so you know that, within our practice here in Washington State. I am a West Coast girl, woo woo. So West Coast, I love that you represented and you're showing that you're here, and hopefully we can get more. I just want to give you some nuggets. Back when they were mining gold, they weren't looking for the large chunk, they were looking for the nugget. And what we're going to be looking for are those hidden gems within our practice that we could be getting some benefits from, that we might not be. And as well as, what if they're not covered by dentistry? If that dental insurance is not going to pay, what do you have to lose? But I also want to share, and we're going to start with this, are your 2021 updates for the CDT. So within the practice, I did not only do medical billing, I did the dental, as well as the treatment plans and the financial agreements, and I was the collection agent as well. But I want you to know what I know, because I try to get the information ahead of time, and sometimes it's not really well explained. Not that the ADA, it's not by any fault of the ADA, it's just sometimes you just need a little more clarity to that code. So I want to go over that with you briefly at the beginning of our webinar here. So of course, the disclaimer, I don't want you to think that I'm giving you legal advice. I don't want you to feel as if I'm pressuring you to bill medical. It's something that you need to think about, and you need to decide, is this something I want to do? I am not going to be the one to tell you that it's easy breezy lemon squeezy. It takes time. It takes consistency, as well as it takes a better head knowledge of knowing what is medical. I can tell you this though, people coming from medical into dentistry, they shake their head at us, but people who are in dentistry that get into medical understand. And so I want to make sure you know, I'm not trying to give you legal advice. I'm sharing with you what I've used. I am not in a practice right now, but I do bill for 6 dental offices myself, because I will not teach something I do not do. So I want you to know that and understand it's important for me that you know that I do what I'm telling you about today. 2021 changes. You knew there was going to be some changes coming up, but I really, and you probably already have your CDT book and you already know a lot of them. And I just want to give a little clarity on what I know about the codes. So I'm not going to spend a great amount of time on it. But of course, as we go through this, if you have questions, oh, by the way, you can also go to our website and download the 2021 changes for CDT in case you just want a hard copy of what I'm talking about. The major change is going to be, you do have COVID testing. Most people do not feel or know that they could do COVID testing in the dental office. They are CLIA waived. What CLIA waived means is that you do not have to be a lab in order to perform this diagnostic test. So make sure to know that the ADA has added these codes, but I want to make sure you understand what code goes to what. So the D0604, that is an antigen test. That is active COVID virus. If you test for antigen, that means whoever you're testing, if it comes out positive, they have COVID right now. But if you do the antibody, the D0605, that means they had COVID. So it doesn't mean they have active virus. So I want to just give you some clarity as to the antigen and the antibody and how those work. Now, I am going to tell you that they haven't said, dental insurance has not said they'll pay for it. Just say it. Medical does. So medical pays. We've had up into $94, $95 per test. But that's something you all need to decide. Do we want to start incorporating this into our practice protocol? Now, the other thing that's changed are, if you'll see the D0701 series all the way to the 709, these codes, even though you see them for x-rays, these are not the same as your D0330 and D0220. That is for taking the image and the doctor reading the image. When you build the 701 to 709 series, this is only capture or only taking the image. In other words, your doctor did not look at them. So if your doctor is not there in order to look at your images, you would need to build this different code, the 701 to 709 series. For your preventative, they have added your counseling for inhaled, ingested, or smoking cessation. Now, we've had this on the medical side, but I'm so glad that they've incorporated it on the dentistry side so that we have an exact correlation as to what it refers to in dentistry. They also have caries prevention medicament per tooth. So that's going to be like some of the things that you apply that's outside of your Arrestin type placements. This is going to be some of the other, there's so many of them, I can't even think of one at this point. So just making sure that you get a good grip on what does that caries prevention medicament. If you have a code in your CDT book, this is not the code to go to. You need to utilize the code for Arrestin, the 4381. So make sure to go towards the code that applies. And if there isn't one that applies and you did use a medicament, you could be able to use this code. Now, your restorative for a prefab, which most dentists, I haven't met a lot of dentists that use a prefab porcelain or crown or ceramic crown, but they have given you a code for that. Now, for your endo, they're talking about your surgical repair for anterior premolar. So you just have a little more defining. To be honest with you, they're really getting more like our medical codes. Medical codes, when we do caries, for instance, they say, is it on the smooth surface or the pit and fissure? And if it's on whatever surface it's on, they want to know, is it to the dentin, to the pulp, or to the enamel? And I think that's exactly what we're doing in these new codes that ADA has brought up, because we're doing the apioectomies to the anterior premolar or molar. You're getting more specific to location. Here's the reason why. If you said you did a molar, the D3503, and then you build it as tooth number 9, would that make sense? Absolutely not. So they're trying to make sure that you have clarity within your dental billing as well. So you have no changes to your perio and prosto. You only have verbiage change. So please make sure to take a look at your verbiage change because that could make a difference on whether they're, I'll never forget crown lengthening. Oh, crown lengthening used to drive me crazy because they used to always say it's aesthetic, no matter what the doctor said. So we had to get really strong on our verbiage within our exam notes. Not the clinical notes, it was the exam notes that they were basing the aesthetic versus clinical crown lengthening on. So again, check your verbiage. Now your maxillofacial, again, they're just giving you extra things to use for maxillary and mandible. They've already had this perio-medicament carrier, but now they're defining it just like they did last year for the night guards, the maxillary and mandible. They're defining it more for the trays for the perio-medicament. Now, for your implants, the semi-precision abutment, and this is the one that's attached. So there's the custom and the prefab abutments for traditional implants, but then you have these the retained screw. That's what that's going to be for. That's a semi-precision abutment. So there's an abutment and an attachment. So making sure you know which one would be which. They're redefining our frenectomies, going from buccal and labial to a lingual, which is what we do in medical, which is great because it gives more clarity as to location. And then going into your surgical placement of your craniofacial implant, things like that, just making sure you understand what it's talking about. But they have deleted some stuff. There are only 4 deletions, so I think that's pretty exciting that we don't have too much to go. They're deleting the 3427, the 5994, the 6052, and the 7960. So please make sure in your practice management software, if you don't get an update, I know some practice management softwares update at the end of the year so they can take out the codes, put in the codes. Just make sure if you don't have that update that you're able to follow through, because if you were to bill these codes, they will not pay them. And there's nothing worse than submitting a claim and not getting payment on it, right? Now, let's talk about hidden gem number 1.
Did you want to answer a few questions real
Oh,
quick?
sure. Yes, absolutely.
It said, for the new D07XX code, do you have any idea if insurance will pay like a regular x-ray?
They are going to pay, but they're going to reduce the fee. Does that make sense? Because remember, when we bill the 0220, that is for the taking and the interpretation. So create a separate fee for just the capture. What they're paying you for is the equipment you use to purchase, to take that image. That's what you're getting paid for, but not the doctor's expertise. Does that make sense?
Okay, and then the next one said, if a doctor is out of the office and we charge out a pano, and they did a D0170, what do we charge out when the doctor returns to read it?
You're gonna do the same, the D330, the 0330, with a remark in there that this was only the reading of the pano. Does that make sense to everybody? So there's a comment section on your claim form, and you need to put in, as long as you disclose it, you are following through. Remember, these are going to be 2 separate codes. They're not going to apply the same standard to the taking and the reading and the both. Does that make sense? Believe it or not, this is what we do in medical all the time. We just use a modifier to tell them if we took it or if we just read it. And I think that's where dental's going.
You do. I mean, you're so cute. It's like, it's true. And what you're saying is 100% true. The only difference is that we add a modifier, and that's what gets paid.
But I think that's what's coming. I think it's coming. And I think that's going to be helpful for us to use just a quick modifier to say, okay, we did this pano, but we did it only to take it. So we're going to put a TC. That's the technical component. But, oh, wait, the doctor's back. We did a consultation. He's reading it. Now we do the same exact code, but we modify it with a 26, which is the professional component. So it makes sense, right? So we have to create the special fees, because you need to realize you're not going to get paid that $225 for the pano because all you did was take it.
Yeah, and then would you review that website where they can find the ADA changes? Is that the DevDent website?
Yeah, if you go to our DevDent website and go to shop, you'll see a free download of the 2021 changes.
All right, thank you. Go ahead, Lori.
Okay, do we have any other questions though?
You're good. I just wanted to get those because they were on the fees that you just went over. So thank you so much.
Yep. So I really think that I would say in the next couple of years, you're going to start seeing modifiers enter into dentistry. So pay attention to those modifiers, because it's really cool that you can explain your procedure without writing a narrative, right? I mean, I could tell you a soft tissue graft narrative. It's like the back of my hand, but I won't. I won't bore you with that. But let's talk about your exams, because let me tell you, you have patients that have kids. You might have more than 1, more than 2, more than 4 exams because somebody knocked you with a wiffle bat. Somebody did this, somebody did that. A baby headbutted you. Well, you know what? There are no limitations to how many exams you can have in medical. So we need to rethink, if they've already used their exams in dentistry, Why not? What have you got to lose? Your patient already expects to pay for it because they've used their 2 exams this year. So why not? But we need to talk about what is the necessity. And it goes back to you're completing your information as far as why are they coming in? If you don't have a protocol, and this is why I think you need a coach, Kay Huff is one of the best coaches I've ever known. You have to have a system. How and when are we going to ask for this chief complaint, which is why we're going to see them today. You know why? Because when we bill our exams, we bill it off of the chief complaint. So if we don't know they're in pain, we can't code that. But if we know we're doing this exam because a patient's in pain, that is our reason. That's our why. So let's talk about what is our medical necessity, how to make sure we note that in our chart note, as well as our symptom-based coding and learning about what the parameters are within that. So I wanted to give you, so the 99201, if you're on here and you've listened to me before and I've talked about the 99201, guess what? They're taking it away from you. So 99201 is no longer going to be effective as of January 1st. And so I didn't even put it up here because I didn't want you to think that you could use that code. But they are starting to lax on your time limitations. And I'm going to get more into that in the beginning of the year, an evaluation and management webinar, so that you can know how they've relaxed this code regarding time limitations and documentation requirements. But right now, I want to make sure you understand our 99202 in medical equals a 140 or a 150. When you go to the higher level, that means you're spending more time. So anything in medical that starts 201, that's lower. 202 is a bit higher. 203 is a bit higher than that. So again, what is our 203 equivalent to? It's our D0180. That's more comprehensive. That might be more things that the patient has. So knowing that these codes exist help you to know what code to use. I'm going to give you a hint. Are you ready? Whenever you do an exam and x-rays, you need to always modify your exam with modifier 25. Because if you don't, they will pay for your x-ray and not your exam, because they think that the exam is part of the x-ray. Modifier 25 says this is a completely separate exam. So that's my hint. No matter what procedure you put with that exam code, modifier 25 all the time. If you're just billing an exam by itself with nothing else, you don't need a modifier to explain. Now that's for our new patients, but our established patients, this is a breeze. How many of you, I'm sure, and I'm sure you've had this, your patients call and complain because you've just charged them $70, okay, that was our fee, for a 5-minute exam in hygiene. Now, we had patients call and complain about that until I said, I'm so glad I only charged you our 5-minute fee. Our 10-minute fee is $152. Our 15-minute fee is $199. Would you like me to check on that time? 100% said no. They would pay the $72 because that was our fee. They'll pay the $72 over finding out the exact time so that I could bill it appropriately. So again, very easy answer for those people who complain about 5 minutes with the doctor. It goes by time in medical. How much time did the doctor spend with that patient? Now, the symptom codes. Why are you seeing this patient? What is their chief complaint? What's that why? Are they coming in with a cough? You can say cough unspecified. And maybe that cough is causing some pain. So they might have a cough with pain. But again, we're talking about the why. What if you have a patient that the doctor has seen erosion on and all of a sudden they're coming back in because things aren't right. Can you use heartburn if they said they had heartburn? Yes, it's a symptom. That's not a doctor's diagnosis of GERD. That is a symptom. They experience heartburn. Here's a key. If you see somebody taking over-the-counter Tums, over-the-counter Tagamet or Zantac, I'll bet you need to ask, have they been experiencing heartburn or a bad taste in their mouth when they wake up? Finding their symptom code is going to explain your why. But again, you've got to create a system on who's getting that information and where that can be located. So that system, we always had a coach. My practice always had a coach. Here's your hidden gem number 2. So number 1 is your new patient exams or your returning patient exams. Again, if they've reached their maximum with their dental insurance, or if they don't have dental insurance, what have you got to lose? Don't promise something to your patient that you don't know for sure. Whenever I started billing medical insurance, I would always say, you know, I'm going to send this off to your medical, but I don't know what they're going to pay. So you need to pay us today. And as soon as we get that explanation of benefits and whatever benefit they'll provide to you, I'll give you a call or I'll send you an email, what works best for you. So making sure you knew, and I always called it my in case I die scenario, my team would know where that information was located. Now, number 2, that this hidden gem is on radiographs. I get so frustrated when a provider says, I need a pano, but I can't take it because the insurance won't pay for it. What? Since when did insurance dictate what the doctor needed to clinically see to treat the patient? How about that CBCT that you have sitting there that you guys have written off 10 of them this week and you didn't charge another 5 because people don't like to pay for it? Well, CBCTs are not covered by dentistry, and there's a reason. They're a medical procedure. So again, what's the why? What's that symptom that you're looking at that causes the doctor to want to see more? You gotta find your symptom codes. Following the guideline of whoever's providing approval for the insurance is important, because like I phoned one insurance as I was doing claim follow-up, and they said, yes, we know you don't want to call the same day because sometimes it takes a long time being on the phone, but you need to call within 2 days to get that retro pre-auth. So can you get a retroactive pre-auth for a cone beam? Yes. Primera Blue Cross here in Washington State, I can get that all the time. But you need to know what the insurance companies, what their requirement is for those cone beams. Do they have retro pre-authorization? Who is that through? And that's what we're going to talk about now. Now, I wanted to give you some scenarios and what it equivalates to. So your D0367 equivalates to 70486. It's also your D0364, although your fee should be different because the 64 is with 1 arch, not 2. So again, making sure you're appropriate, and we would modify that code with a 52 to downsize the effects, because it means the 52 means we didn't do everything the code entails. Now, did you know you could do an FMX? It's a 70320, a Pano 70355, a PA 70300. But what's your why? What does the doctor need to see based on the patient's symptoms? So what are the symptoms? If you say, well, they have an infection, then I'm going to go K12-2. That's an infection. The doctor wants to see how much of an infection that patient has. That's a very legitimate reason of why you take a cone beam. But you know what? A lot of times this frequency limitation gets in our way. The low allowables in dentistry get in our way. And that they're denied because, like I said, the cone beams are not a covered benefit. So we just got to realize, we have swelling. Did you know R22.0 is inflammation in the head? Not in the brain, but just in the head area. So we just need to figure out what's the why. If we can get that, we're going to be good. Now, I wanted to give you some of the insurance companies that use these radiograph people. So all of these companies are throughout the United States. You can create accounts with them for free. You don't have to pay them to get pre-authorizations online, but you will if you don't have an account. I wanted to give you the reasons why they would pay for a CT or a CBCT. Is evaluation of the sinonasal cavity, assessment of osteomyelitis, diagnosis for parotid or salivary stones, or even if a patient has dry mouth and the doctor wants to look at if there's salivary stones within the salivary glands. Also assessment for trauma, diagnosis of facial abscess, infection again, or even a follow-up study. Say, for instance, you did it for to see what the level of bone was. You did a bone graft, and now you need to see if it's healed and hardened and integrated. Well, that's that follow-up study that they're talking about. So again, the documentation requires a medical reason. In other words, you can't say, "Oh, we do this for everybody." It doesn't fly with medical. You need and you have to have a why, because that is the whole basis of imaging. How about this? What if I go to the medical doctor and I tell the doctor, you know what, my finger hurts. And he says, well, I'll take an x-ray of your finger. I'm going to take an x-ray of your toe too. And I'm telling him what hurts, my finger. And he takes an x-ray of my toe. Is that medically necessary? No. Because I told him my finger hurts. I said nothing about my toe. We have got to get back to actually listening to our patients. It's so important. Now, the other one, oh, I'm sorry, I didn't even say the group. So it's Magellan Health. It's also considered RADMD. A lot of Blue Cross Blue Shields use that over in the Midwest to the East Coast. What you need to look at for the West Coast gang, AIM Specialty Health is huge on the West Coast. I have an account with them for some of the providers that I bill for here in Washington State. But I wanted to give you again why they would pay for this cone beam. And it's an amazing process. Did you know at the bottom you see arthropathy and arthralgia? Do you know arthralgia means pain in joint? So if I said you had arthralgia, they want to know, is it right, is it left, or is it bilateral? That is the whole definition of that code. So we just need to go back to using common sense. And I think if you think about the common sense status of this, you're going to do just fine. So what else? They're looking for osteonecrosis of the jaw. How about this? Osseous lesions or tinnitus or calculus and plaque. Wait, you mean somebody who might need scaling and root planing could get a CBCT covered because they have accretions? Accretions are calculus and plaque buildup. Yes. So we just got to go back to thinking with common sense. Dental insurance has your mind totally twisted around. You and I both know, you do a claim, you literally have to send your blood type and your firstborn child just for them to get it paid, with your narrative, your pre-op photos, your post-op photos, your pre-op intro or your pre-op x-rays, your post-op x-rays, your full arch x-rays. I had groups, we were perio. They wanted x-rays for tissue grafting. And I said, the doctor said, you don't need x-rays for tissue grafting. You cannot see tissue on x-rays. And they said, well, we require to see x-rays for tissue grafting, which makes no sense because you can't see it. So again, different reasons. I wanted you to just see that, and these were obtained directly from AIM Specialty Health. Again, it's really hard. Website's hard. aimspecialtyhealth.com. Create a free account. You'll be able to get pre-authorizations done online. EVCore is another one. EVCore, actually, EVCore ranges from the east to the west. So from the east to the Midwest to the west, no matter, EviCore is one, some people pronounce it EviCore. I like EviCore, it sounds better. But one of the reasons that they do this, again, you can kind of see similarities in why they would cover services. Sometimes all it takes is a little more explanation as to what you're looking to see. I've written many narratives or letters of necessity for CBCTs, and it literally takes me 2.5 seconds. And I usually can fax it over there and they get it processed right away. So again, rethink what you're doing. Now here's a scenario. We have a 19-year-old male with a bad taste in his mouth, visible external inflammation. On the upper right, a CBCT was taken to determine the amount of infection. So I say that because apparently the doctor's already diagnosed infection and swelling. So let's look at some diagnosis codes and choose what we would use on this claim for the cone beam. Would we use infection? Would we use atrophy, which is bone loss? Would we use dysphagia, which is difficulty swallowing? Or would we use a fistula? Or I think I forgot swelling, sorry. So what would we use? Let's see, Kay, let's see if we can have, if somebody answers this. I'll give you a hint, there's 2 of them.
Okay, let me see, let me start my video.
Oh,
So,
Mark got K-12 too.
So put it in the Q&A, guys. So she's going to ask a question.
Okay, there's one more, K-12 too, because we said there's infection. There was already diagnosed infection, but the doctor wanted to see how much. So what else could we use according to the symptoms? Francis got it right, 1 and 3. Patient said they had swelling, and we doctor diagnosed the infection. So those would be our codes that we would use for this claim, because look, we circled 1 and 3. So again, having that notation helps you as a biller to know what is appropriate to use. Now, here's your hidden gem number 3. This is where I feel emergencies and traumas are commingled. Because if you have an emergency, there was some kind of trauma involved. Because say, for instance, you have a patient in pain. Is pain an emergency? Yes. It might not be trauma-based, but it is still an emergency, especially if you note it in your notes. Now, what they do not go with is that you have an emergency and you put it off for 2 weeks to do the procedure. So you do the exam as an emergency, but the procedure does not need to happen for 2 weeks. Unless you can explain that, like the patient needed to be on antibiotics to calm down the inflammation. That's an explanation. But it still requires the treatment to be emergent. So do you see what I'm saying? The treatment you need to do as an emergency is basically what you do. Doesn't mean future treatment is a part of that. But when it comes to trauma, trauma will follow full circle. Trauma can follow from your exam to the next phase where they might need to do endo, to the next phase where they might need to do crowns, to the next phase where they might need to do ortho. Yes, I said ortho. I've had it covered through trauma. So we have to rethink it. It followed my patient for 2 years as going through the different specialty clinics, and they were able to bill because we coded it originally and they could follow our coding. So think about how much more you could help your patients if you had a policy and procedure in place for your emergencies and traumas. It's a gem. You know what a gem is? A gem is like, I'm going to take a diamond, a piece of coal that gets pressed. Do you think that the coal was happy about getting pressed and pressed and pressed? It was uncomfortable. Sometimes even a bit annoying. Medical billing is like that. To get that gem, you need to press and press and press. And you need to fine tune all the time. Just because you have a system down doesn't mean that it can't be improved. Always, our practice always improved. Great staff, great team. We worked together and they were fabulous. But we constantly had to have fine-tuning meetings to get things back in order because we get a little lazy. I don't know about maybe my practice was the only one, but we got a little lazy. And so we had to revisit what we were about, what we were trying to do to help our patients. Now, with emergencies and trauma, you need specific documentation. You also need to get the information before the doctor sees the patient. Because if your patient says, you know what, I got in a car accident yesterday and I hit my teeth on the steering wheel, and you don't know anything else. You don't know if the patient's in pain. You don't know if the teeth are mobile. What if that tooth fell out? And you don't know because you didn't ask. So we've got to get better triage questions. And you've got to know what the scenario is. What are we looking for as a team that constitutes an emergency or trauma? Now, my number one, have an accident form. This accident form, whether you create one yourself, which is what I did, because if you have an accident in the home and the patient doesn't even go to see a physician, you need something in the patient's handwriting that tells you what happened. You can't say, just trust me, insurance company. You need to let them know you have an accident form on file. It's important. Now, I've only had to send it to the insurance company one time, but it will establish your practice as one that follows through and has the emergency protocol by having the patient complete the accident form. I call it an accident incident because that's exactly what it is. It could be an accident, it could be an incident. What if your husband's stretching early in the morning and all of a sudden doesn't realize your face is right there? Well, okay, if he knocks out your tooth, most people think, well, that's not going to work. They don't consider that an accident. Want to bet? So we've got to have the details because that's how we would code that trauma. Anything that the tooth sustains trauma on, we need to be able to document it and code by it. So it's important to have the details. And this goes from the details like I told you about that other case. That happened to be a flight attendant that was at a football game tailgate party where alcohol may or may not have been involved and fell flat on her face. She broke 8 and 9, 24 and 25 were avulsed. She had to have root canals and crowns placed on those. And because 8 and 9 were fractured in a way that changed the shape of the maxillary arch, Dr. Gottlieb had to put her to ortho because if he would have placed implants in there, they would have broken because of the way the structure was. So she followed her all the way through. And that's why it's important to make sure you have your own accident form on file in case, I say that in case you don't get a hospital report or a paramedic report. So it's really important. Here's my definition for medical emergency for dentists. Gum abscess, pupil abscess, swelling, bleeding, broken teeth that are causing pain, pain on biting related to infection. I'm going to take out cracked tooth. If we were to code cracked tooth, every single claim comes back that this is dental in nature and has no health benefit. And so I really want our dental offices to take cracked tooth. It's a fracture. And I hope that dental providers would agree. If I'm wrong, please tell me. I mean, I'm totally open to being wrong. But a fracture to me is anything that's broken. So again, if it's broken, it's fractured to me. Inflammation causing pain around wisdom teeth, that is an emergency. We've actually, during the COVID period when we were shut down, we have offices that use our service that had to extract wisdom teeth due to inflammation and infection that could have turned septic had they not moved forward with surgery. So important, and medical insurance did cover those. and as well as trauma due to accidents. So those are emergencies that I think are important. Now the symptoms, I think, remember we talked a lot about symptoms and how our exams are symptom based, but maybe you could create your own questions regarding the symptoms of infection or cellulitis. Is pain and tenderness in the affected area, red or inflammation of your skin, a skin sore or rash that grows quickly, tight or glossy skin? You know, when I'm allergic to mint, and when I was trying to figure out exactly what it was about, I didn't know it, but my lips felt really tight. And I'd ask people, are my lips swollen? And they'd say no, but man, they felt really tight. And I felt like they were swollen. So again, your patient could feel it swollen or tight, glossy, and not realize it, might not look it to you. But if they feel it, there's something internal. An abscess with pus or exudate and a fever. Now, I want to go back here real quick, is that an immediate implant placement is not usually payable because of the emergency. I'm not saying that it's not going to be payable, but you have to be careful to denote, is this an emergency to place this implant? Taking the tooth out, cleaning it out, putting bone, putting a membrane, yes, that's all part of that emergency, but not necessarily an implant. So be careful. I don't want you to say, well, Lori said it would be covered, because sometimes it's not, especially if it's an HMO or an EPO plan. Now, I wanted to give you how it would look on a claim form, especially noticing box 24B, or C, I'm sorry, 24C. Do you see that Y on all 4 of those lines? That is telling the insurance company these services were an emergency. The EMG stands for emergency. 24G, a little further right after the fee, that number tells them how many we did. So in other words, if I put 1, that tells them that $1,200 is 1 unit. If I said $2,400 and I had a 2 in the units, it would let them know that my per unit fee is $1,200, because the $2,400 constitutes 2. I gave you diagnosis codes and how they would relate, as well as showing you in 24E how I'm pointing to each code because of the service. Now, I'll give you a little information. The 21210 is down at the bottom, a 7953. The 15574, the 4266. The 41899 is my 7210, and the 99202 is my D0140. So that you can get an idea of how it equivalates from dentistry to medical. Now, this is the same one. Just ignore this. I forgot I didn't take. Oh wait, no, it's kind of not the same one. This is a 19-year-old. We have a lot of 19-year-olds apparently. Bad taste, visible. He did a telehealth conference. They could see a visible external inflammation, upper right. They did emergency treatment, but instead of just that one scenario of the CBCT like we did earlier, he also had an extraction, a bone graft, a membrane, and a sinus closure. Now, let's look at what codes we could use. So I told you what the scenario was, and now let's see what could we use. I want you to look up upper left, the diagnosis codes. I gave you A, B, C, D, E, just like I would on a claim form, and what they mean. So he has a partial loss of teeth due to other. That other is the abscess. So there's 4 causes: trauma, other, caries, perio. Those are only 4 causes that you would have a partial or a complete loss of teeth. It was due to other because of an abscess and the inflammation, and the patient has pain. And we're doing the bone graft because of the atrophy in the maxillary arch. Now, how did we code this? Our procedure codes are on the left of the procedure. The dental codes are on the right of that. and then how I'm pointing them to each diagnosis code to tell this patient's story. So if I say A, B, C, D, like I did in number 1, I'm telling you my patient has a partial loss of teeth due to another reason, which is an abscess and inflammation and pain. Did that tell the story of my patient? Yes. Their end result was a partial loss of teeth. The cause was the abscess, pain, and inflammation. Now let's talk about this. I know we have some questions, Kay. I kind of want to stop here and answer those questions real quick.
Fantastic. Hold on one second and let me just get going and get to the questions. So yeah, we have quite a few. So it says, how do we get medical to pay if a patient hasn't met their deductible?
You have to meet their deductible. One thing I want to say, if your patient has a deductible, whose deductible is it? It's theirs. And if you meet their deductible, have you helped them? I mean, that's just, I don't know what else to say on that. We in dentistry sometimes feel bad, and we feel like we have to make a reason why our services are valuable, and we don't. You didn't pick their insurance policy. You didn't pick their deductible. How about spin it the other way? Hey, Kay, we were able to maximize your benefit by meeting your deductible with your medical insurance. So that's great. So now you can have additional services if you need it, and that deductible is going to be met. Instead of saying, okay, we met your deductible, sorry.
Yeah,
we don't want to do, we got to turn it around.
I'm going to say this, Lori. You know, we have trouble with just getting their doctors to get their fees up to where they get paid the right amount. The thing about medical here is that, you know, what I've seen you get back from insurance companies, you know, a doctor really, they want to do better for their practice. They want to buy better equipment. They want to do more. Right. They can't afford it. But yet, if we would take the time to learn how to do medical, I mean, just this week alone, you've gotten paid what on what that one.
So one of the claims that one of my offices I bill personally for in Florida, I was able to get him over $11,000 from TRICARE for crowns, caries, scaling and root planing, and what else? Endo. Those 4 things were the major. They didn't even do implants. Those were the 4 things that we got covered. And so again, TRICARE will pay. You have to do it TRICARE's way. That goes back to education. You know, you have to know, what does TRICARE require for me to get paid for this patient? And because we did it the right way, well, I guess luckily because I knew how to do it, we were able to, and you know what? I told Kay, I'm working on a case study for this. So we billed it on October 5th. They got paid on October 23rd, $11,000. So I'm just saying, there are things that you can do. It's not going to be tomorrow that you're going to get $11,000. Because you've got to start learning how to do it, right? I didn't get $11,000 my first claim. But you know what? As I've grown in learning, I've been able to access, and I think that's why we're here. We're here to help each other, right? Because if your practice succeeds, it makes it better for all of us. And so that's why Benco puts these things on, so that they can make your practice better, so you can get the things you need and give the raises that are deserved. So
the next question is, it says, okay, let's see. It says, with medical, let's see, what medical claim system do you recommend? So what system? So you want to do the dent? So we will go over that towards the
we're going to go over it at the end, because you know, you have to decide, and Kay, I tell this all the time. When I teach a class, I teach you every way you can bill. How you decide to bill has to be a practice specific decision. So you cannot say, I don't expect everybody to use us. I don't expect everybody to bill online. I don't expect everybody to bill on paper. You have to determine what works best for the staff you have and the clientele you have.
And then this one, it says, medical seems to be very pre-estimate driven. We've had a patient that tells us their treatment has solved their sinus issues, can we go back and bill this to medical now?
So you have 1 year. That they have a time limitation just like in dentistry. So you can go back 1 year to bill. So if it's been within that year, absolutely.
And then the next question is, I am not understanding why would I bill for an emergency when I already billed dental for a 9110 or an 0220, etc.
So if you've gotten paid from dental, I'm not saying to bill. I'm saying if they've used all the benefits and you're not going to get paid, what have you got to lose?
And I want to say one more thing to that, Laura. I'll say this. If it's someone that's coming in for an emergency of an accident or, trauma, you want to bill medical because dental's going to run out and medical's not. Am I correct, Laura?
Oh, absolutely. Not only that, but if you decide to bill dental instead of medical, medical can say, nope, you thought it was dental, you can't bill us.
Yeah, that's interesting. So the next question is, are you suggesting to bill both medical and dental for the same visit? So that's the next question.
Not at the same time. So you have to decide as a practice, what is it that makes this service medically necessary? So if you can't answer that question, in other words, a diabetic, when you clean the oral cavity and you keep it up to date and basically as bug-free as possible, you help their HbA1c, their glucose level. So can I say by doing perio maintenance on a diabetic patient that it is medically necessary? Yes, 100%. Can I say helping a diabetic have full function of their oral cavity can help them be with a better HbA1c? 100% I can say that. How about a GERD patient? If you have a severe erosion for a GERD patient and you do crowns, will it help their overall health by saving that site? Yes. Had a prosthodontist in Colorado through Kaiser Permanente, got $7,000 for crowns because of a GERD patient. So again, doing it the right way, following, not everybody requires pre-authorization. I know somebody said that earlier, but you need to know, do they or don't they? We do that at Imagine Billing with a verification of benefits. Each code is called and asked on, and we find out, do they require pre-authorization? Will they allow no pre-authorization? So we always get a call reference so we know exactly which code has to be pre-authorized and which code does not. So we also want you to do the same. We really don't want to do it for you. We would rather you do it, but you need to decide that upon staff. So let's move forward on symptoms of an incise and drain. Again, kind of the same, raised or rounded skin, warm to the touch, drainage, exudate, swelling, inflammation. So when you're looking for an incise and drain in medical, those are the symptoms that you're going to be looking for. And this is kind of how an emergency, again, 24C, there's a Y, that means it's an emergency, and exactly how I would code that. One thing I want to point out, my highest fee is my #1 service because they will downgrade, or not downgrade, they will pay highest on your first fee and reduce your multiple fees. So I want to get paid the highest or the most on my highest fee, whether that be my implants or my bone or whatnot, or my cone beam. I'm going to put my cone beam first and then my exam. Whereas in dental, they do it by the way you enter it. So please make sure to note that. Again, I gave you the legend of exactly how you would look at this dentistry-wise. And pointing you with your diagnosis pointer 24E, how it tells that story. My patient has inflammation and pain, and therefore we found an infection. So it really does tell the story. Now, your emergency treatment due to trauma. And this is your auto accidents. You're accidentally being struck by someone. We've had lots lately of basketball injuries, of people flailing their arms and legs and striking somebody in the mouth. And intentional strike. So remember, there are intentional strikes. I had a barroom fight. That's an intentional strike. And then falls off bicycles. Do you know there's a code for a fall off of Heelys? I know, because I bought my granddaughter Heelys, and I had to find the code, so when my daughter said she would break her neck, I could tell her there's a code for that. So I'm just saying there's a code for everything. Anything you can think of, they've come up with a code. How about being struck by lightning twice while on skis? There's a code for that. Now, triage questions. I wanted to give you something that you can pose to your team as far as what are we asking? What is the intensity of pain on a scale of 0 to 10? I know we're running out of time, and so I'm not going to go through all of these. If you'd like them, email support practice coaching at Benco. I'll get this whole list to Kay for you, so you can have it on one sheet, and you can create this however you'd like, as well as I just go through all of the things you'd want to know for triage, because if you have these questions answered and your doctor says if they have any pain, they need to be seen right away. But if you don't ask, you might put them out 2 weeks, and who are they going to be mad at, the doctor or you? They're going to be mad at you. So get the triage questions for your practice. So I gave you a legend of an emergency reimplantation of an avulsed tooth because the patient fell off their bicycle. So I just kind of wanted to give you an idea with your CPT and CDT legend to the left. And then again, I know we're running out of time, and I hate running out of time, but you've got a 22-year-old female looking at what codes we'd use, giving you that scenario. I'd be glad to send this to you. Again, I'll get this to Kay so that practice coaching can get you the information so you can actually see it. I hope that would be helpful. And your endo infection. Do you know endo infection can leak into the brain and turn the body septic? So an endo infection, if your doctor says it's severe, note it in the chart. Severe infection, if not treated, could turn septic. That would be the note of why you need to do it. So again, what are you doing? Either there's only 2 reasons you do endo: removing a lesion or removing a foreign body in the hard tissue. That's what infection is that foreign body. So it gave you a little bit of ideas of diagnosis codes that would work for that, as well as how that could look on your claim form. I'm going to bypass this, but I am going to give you those codes because I want to show you success, right? It's one thing to tell you all this stuff that we do without showing you success. I have so many more, and I have to update this to give you better ideas. But I gave you, this is, if you notice, the 70486. They were allowed $281 of their $395. That's pretty cool. And they actually paid it all out. And going through again here, notice this office, that $5,000 K is for a night guard. A night guard. I do not recommend that, but they allowed the whole $5,000. They paid $4,230. Now their cone beam, they charge $1,500. I don't recommend that either, but they paid $659.72 of that. So I'm just saying and if you look down below that exam, the reason they didn't get paid on the exam is they forgot to use modifier 25. It's the whole reason they didn't get paid. But they were okay with it because they liked the amount they did get paid. So again, the visit allowed $57.33, they got paid $48.89. Not too shabby. Can anybody tell me they got paid that from dental? Not one of you could do it. Now, tori removal and a cone beam. I just wanted to give you some samples. And again, I'll get a copy in PDF of the slides to Kay, and she can get it out to you. So practice coaching at Benco. Don't forget to reach out if you just want to see success. I'm not saying this is how every single claim of yours is going to go, but I'm saying that if these people are having success with the different insurance companies, so can you. Again, looking at Blue Cross of New York, noticing that they're paying on an exam $126.40. So you just need to know what other people are. This is a Medicare Advantage plan. And the service they did was an exam. They charged $91. Wait, Medicare, remember? They paid $74.21. Medicare. So think differently about what you've got going on at the practice. Now I'm at Q&A. Not too bad. 3 minutes over. I'm sorry.
That was amazing. You know, I want to say this again. You know, we've hosted Lori for a lot of workshops and webinars, but guys, you know, I think it's there, it's written out there. We can get the money, you just have to know how. And you know, with dental insurances cutting back on a lot of what they're paying us right now, this is just a different way of thinking. And you know, we have someone who's had success, you know, we just want to open it up and really say, you know, think about it, because I think it's really good. So if you could stop sharing your screen for just a second, Lori, I'm going to let Maria go on. And there's 3 questions. Let me just see really quickly. Let's see. So what medical claim system do you recommend for the office? You want to go ahead and talk about your software now?
Yeah, so we have a medical billing software for dentistry. So if you go to devdent.com, you can schedule a demo. It goes, you put your dental code in, we tell you what it crosses to in medical, and you can choose. But we do all your follow-up, and that is like winner chicken dinner. So once you put your claim in and your patient walks in and says, Kay, what's going on with that medical claim? And Kay says, I don't know, I haven't called in about a month. Much different. You log into your cloud-based software, you say, hey, our biller's called on this date. This is exactly what happened, and they're going to call again on this date. You are on top of it, and that was important to me because at the practice, I didn't have anybody to do that. It was all on me, and I felt horrible not knowing what was going on with my own patient's claim. So go to devdent.com. You'll also find other additional things there that you might like. If you don't, again, you figure out what works with your practice dynamic. If you are short-staffed, I am not going to tell you to do it yourself, because you're gonna get more frustrated and you're probably going to say bad words.
Yeah, and I will say this too. This is something that Lori also said that was really good in her workshops. You can't do it alone if your clinical team isn't also taught how to gather the right information to allows you, because there's certain questions that have to be asked. And you know, Lori, I don't know, but you guys, if you're open to a workshop and you want to learn more, let me know in the Q&A. Say, I would love to be, I'm interested in a workshop. And Lori does some workshops for us. If we can get 25 people to take a workshop, I know Lori would absolutely love that. And we really do a deep dive in it. So please think about,
we have fun.
Yeah, and we have fun. We do have fun. And then I know we're running a little bit late, but Lori, they also want to know, where do we get medical claims? And that'll be the last.
I buy mine at Amazon. They're the CMS 1500. If you email practice coaching at Benco, they have the PDF fillable that you have to have that specific claim form. You can't just print it out in black and white, because most of them will not accept it. It's a special red. I've argued for 2 hours over this, so don't even try. You're just going to say bad words again. But get the claim form, email practice coaching. They can send you the PDF that I sent to them, and then you can type it all in, put your claim form in, and it'll print only where you've typed.
Yeah, and Rita, I do see that you have some other questions. Don't worry, Laura will answer those. I know you have a few. You want that slide again? She'll make sure she gets that to you. She never leaves anything. And so, guys, please let me know in the Q&A if you would definitely like Laura to do a workshop. I think it's worth it. I think that you deserve to get paid. So, Lori, again, thank you so much for everything. You always make it interesting. I was taking pictures. I was super excited to see that you already have the new codes for COVID. I think that's that's fantastic. So you're always on top of things. I'm super lucky to have you on my speed dial. So thank you so much.
You know what? I love Benco. I love Kay. I love Maria. I love Chuck. And you know what? We're here to help each other. And I really think that's what it's about. And, you know, if we're not willing to help each other, we're in a sad state.
Yeah. And I will have to
about the upcoming.
I need to give a shout out to Larry Cohen, the owner of Benco, is also on listening to you. That's how much they really care. So Lori, wave to Larry and say hi.
Hi, Larry.
He said you did a terrific job. So guys, if you want to know more, you're welcome. If you want to know more about our upcoming webinars, please take your cell phone and scan this QR code, and that will take you to our website. That will give you a list of all of our upcoming webinars. We definitely want to make sure that we do more for the West Coast. This is our first one, and thank you, Laura, for opening that one. But we do have others on Wednesday, so let me know if you're interested. We have a great one coming up Wednesday, December the 2nd, and it's Does Splatter Matters, and it's talking about hygiene. So Donna Schultz is going to be doing that. Amazing teacher. So please sign up for that free webinar. It's going to be at 12:45 to 2 o'clock, and it's again 1 CE. And then we have another one, opioid addiction. And you know how hard that can be on a practice, you know, to be able to identify that. And this doctor does an amazing job. And Dr. Parsons is going to really be telling us what we should be looking for, and you know, through her own experience, and it's just an amazing story. So you're not going to want to miss that webinar on December the 16th. Again, I want to say thank you for everything. And then, we have a special report. Lori, why don't you help me with this one? So,
okay,
a lot of things going on right now.
Yeah. So there's a new test out. So there's actually a couple new tests that dental offices can do once they obtain the CLIA waive certificate, which I'm going to send to Kay as well. So again, all these things, if you want to be able to do COVID tests within your office, you just have to obtain a CLIA waive. What CLIA waived means is that you are not a lab, therefore you don't have to have an overseeing medical physician to look over your results. And it literally takes the CMS about 2 days to process. And once you get that, you are able to obtain all these CLIA waive tests, one of which is COVID, and there's another one for influenza A, B, and COVID. So depending upon what you want to look for within the practice. And so with when Paul Jackson comes up, you'll have special medical coding information along with the dental coding information, depending upon, again, dental's not going to cover it right now. They might later on, but they're still not covering HbA1c tests. And that's been several years they've had that code. So
that's going to be a great webinar, guys. Please make sure you sign up for it. Rick Cohen's also going to be on there talking about the glove supply. So that's going to be on December the 3rd from 1 to 2 Eastern time. So please, if you're interested, make sure you sign up. Even if you can't make it, if you sign up, you'll get a recorded copy of the webinar later to you. And then we're also going to be having a workshop at the end of the year. I'm going to be doing a workshop along with Linda Anderson, one of our business coaches, on how do you close out your year. I know Lori kind of talked about that a little bit. How do you close it out, and how do you reset and re-engage for next year? So we are super excited about this workshop. We are going to have limited seats. It's $49 a person. It's a more deeper dive. It's a 2 hour. You'll also receive a workbook. If you're interested in attending this workshop, please reach out to us. It's going to be on December the 4th, and it's going to be from 1 to 3 Eastern time. So with that being said, I know we talked about this later. If you have any questions about tonight's webinar, I would like for you to email me personally at my email, which is khuff@benco.com. Again, that's khuff@benco.com. Any questions or any information that you need to get to Lori, let me know, and I'll make sure we get everything out to her. Thank you so much for
thank you for letting me go over a little bit.
Yeah, and please have a very nice and safe Thanksgiving.
You too.
Thank you so much, Lori.
Bye,
Bye-bye.
everybody.